Okay, so I understand that everybody here are students at the podiatry school in Karachi. Is that correct? Okay. Well, I am here with Dr. Arwa Akram as well from the United States. If you wanted to come and introduce yourself, Arwa. Dr. Akram, I mean.
Hey, Assalamualaikum everyone. My name is Arwa Akram. I am originally from Pakistan, but I've lived in the United States for about 20 years now. I went to podiatry school with the other presenter here, Ali. We did a residency, and both of us are in practice now. I apologize for voice. I'm a little bit under the weather. We have a little presentation here for you guys. I hope it's beneficial. If you guys have any questions, join MPN and please feel free to ask us. I'll let you take the lead, Ali.
Yeah, thank you. So we started the Muslim Podiatry Network, or MPN. I guess that was 2023, and Dr. Junaid Khan, who's also, I think he's on the call, if I'm not mistaken. It was kind of an idea to get Muslim podiatrists together so that we have a voice, basically. There was a lot of things going on in the world around that time. Well, always, but around that time specifically. And we were, seeing things that were unjust in the professional world as well, actually. And so we wanted to get some Muslim podiatrists together and have kind of a unifying voice, or at least resources to provide to Muslim podiatrists. And so that's what we came up with. And our mailing list, we've got over 150 to 200 people. We have a pretty big Instagram following as well, so we encourage you all to follow us too. It's called the Muslim Podiatry Network on Instagram, and we post things that are happening in the Muslim community. We also do little case presentations. We'll do webinars, so it could be helpful. So let's go ahead and I have a little presentation about podiatry in the United States, and then Dr. Akram will talk about, I guess you've got a couple case presentations, correct? Okay, great. Shehzad, actually, are you able to hop on the call here and kind of just tell us about your all school and what kind of your curriculum looks like? Or maybe we can do that afterwards. Let's do that afterwards. I'll just go ahead and start with mine here. Give me 1 second to share my screen. Let's see. All righty. Arwa, can you tell me if you can see the screen here?
Yeah, I can see it.
Okay, great. Good. So podiatry in the United States. So I'm Ali Ahmed. So our designation is a DPM. It's a doctorate in podiatric medicine. I practice at the University of Kentucky in the Department of Orthopedic Surgery and Sports Medicine. And this is in Lexington, Kentucky. And so we'll go ahead here. So a little bit of an overview. We'll talk about the history of podiatry in the United States, the education and training, the scope of practice. And then actually I took out the infection workup. We'll just stick with the first 3 bullets there. So about myself, so I grew up in Louisville, Kentucky, which is about an hour away. And then I went to college in Cincinnati, which is also an hour away. And then Dr. Akram and I went to Rosalind Franklin University in north of Chicago. And then I did my residency training in Salt Lake City, Utah. And then now I'm back in Kentucky. I think some people are still joining here. There's a way that I can admit people while presenting. Let's see. Yeah, I should just turn on the thing so that it just joins automatically. Sorry, 1 second here. Let me see if I can just make it so that I don't need to sit here and admit people. 1 second. I'm not seeing how to do this here. Whatever, we'll just have to break and I'll just keep admitting people as they join. All right, you all can still see my screen here, the presentation.
Yeah.
Okay, so in the history of podiatry in the United States, well, in general, I guess, so in ancient civilizations, and there's hieroglyphics in some of the pyramids and things in Egypt that show that people were taking care of other people's feet. So it's been a long-standing profession, so to speak. And in the 1800s in the United States, there was a profession that developed called chiropody. And so basically, chiro is the Latin prefix for hand, meaning hand, and then podi, meaning foot. And so this was a person who basically took care of hands and feet. And so they were looking at trimming calluses and trimming nails, things like that. And in the 1900s, well, I guess going back to the 1800s, during the United States, the tenure of President Abraham Lincoln, he actually had his own podiatrist, and this is the picture of him here on the side. So it's something that had been going on for a long time, and that people actually it was pretty common. In the 1900s, they actually became fully licensed, and they started developing schools of chiropody. First one being in New York City, and then the second one shortly after being in Chicago. And there they would learn basically kind of the same thing. They would learn about taking care of the feet, and they would learn about different types of shoes and trimming, whatever, like I said, nails, calluses. Sometimes people would have injuries to their feet that they would, cast and things like that. And then the World Wars started. And I guess there was an official title for the enlisted chiropodist called the Chiro Corps. And so those people kind of got together and took care of people's feet during the war. And then that kind of escalated, actually. From there, I guess there was a lack of medical trainees that were involved in the war. And so they ended up just kind of enlisting these Chiro Corps people to basically take care of anything related to the foot, including fractures, whatever it was that you do during wartime involving your feet. So, and then, underserved conditions of basically, during the war, there was things involving surgery that they kind of just employed these chiropodists to do. So it really has to do with the war, with World War I, World War II, where things kind of got serious for podiatrists in the United States. So now there are 11 schools in the United States, kind of all over. It requires an undergraduate degree, so college. So here we do. I don't know how familiar you all are with the education system here. Basically, you start school at the age of 6, and then you kind of go until the age of about 18. That's the end of high school, and then following that, you can choose to go to college, which is generally speaking about 4 years, but people can get done sooner than that. So you require, the podiatry schools are after that. And they require that you have the undergraduate degree, and then you have to take the MCAT exam, which is the medical exam for both podiatry schools as well as MD designated schools. Podiatry school is 4 years, and years 1 and 2 are generally basic sciences. So we're taking biochemistry, pathology, physiology, anatomy, all of that. And then we take our first board exam, which is called the APMLE. And then after that, years 3 and 4 are mostly rotations, clinical rotations. You go to different hospitals depending on where you want to go. You get to kind of choose. Some of them are required that you stay in certain areas. And so that's what years 3 and 4 are. And on those rotations, we're not just doing podiatry. We're also rotating with general surgery and orthopedic surgery sometimes, emergency medicine, hospital medicine. All of that is kind of covered within our 3rd and 4th years. After that, you take the APMLE Part 2, And then once you graduate, you end up with a doctorate in podiatric medicine. Let me admit a couple people here, sorry. All right. All right, and then so after our 4 years of podiatry school, you then have to do a podiatric residency. This is required, and generally speaking, they're 3 to 4 years. There's 1 or 2 programs in the United States that are 4 years as well, but most of them by far are 3 years. And again, on this, in residency, we do on and off service rotations, those being, obviously podiatry related, surgery related, but then also we do medicine related stuff. So hospital medicine, emergency medicine, all of those. There's often dedicated academic time during this. So residents are expected to participate in journal clubs, meaning reading, up-to-date journals, presentations, a lot of academic related things. Some programs require residence or research as well. Some of them don't. It just kind of depends on your interest in the program itself. And then we took the APMLE Part 1 and 2 during school. A lot of times in residency, you take the APMLE Part 3. So this is equivalent to, not equivalent to, but it's the same sort of timeline for like the USMLE. I'm sure you all have heard of that for people who want to practice medicine other than podiatry. We use a logging system called PRR, Podiatric, Residency Resource, and basically that's the way that you log all of your surgical encounters, all of your experiences related to podiatry throughout residency, and I'll show you what a snapshot of that looks like. So after residency, there's an optional 1 to 2 year fellowship. There's a few programs in the country that also have 2-year fellowships. Most of them are 1 year. And in our fellowship, again, this is optional. You focus on various things depending on what you want to do. So there's more orthopedic related fellowships, more reconstructive surgery fellowships. Some are like more sports medicine related, limb salvage. There's a couple of research ones. There's also a couple of pediatric related fellowships out there. And then we also take professional boards. So there's 2 boards in the United States. One of them is called the American Board of Podiatric Medicine, and the other one's called the American Board of Foot and Ankle Surgery. So you may, well, if you guys have questions about this, feel free to ask me at the end here. But there's basically 2 boards. And so throughout after graduating from residency, you have a certain amount of time to compile surgical cases, and then you actually submit those cases to the boards to sit for the boards, and then they hopefully certify you if you do well. And these are both forefoot related. So we kind of, the American Board of Foot and Ankle Surgery splits it into forefoot and then rear foot. So there's 2 separate parts within that. And then we have to basically get recertified every 10 years, which I think is kind of changing nowadays, but let me omit someone here. Okay. Yeah, this is not really necessary. Basically, this is how residency is broken up. This is in my residency program, the top being it's not worth getting into. I'll just keep going. So this is that PRR I was talking about, which is basically, this is a snapshot from my 2nd year in residency. Basically saying the green bar is me fulfilling my requirements for my podiatric experiences during residency. So the scope of practice for podiatry in the States, it really depends state to state, also hospital dependent too. So some states allow podiatrists to do foot, and then you kind of stop at the level of the ankle. Some of them say, no, you can do more soft tissue, muscle, skin stuff up to the knee. So it really kind of depends on the state. If you see here for Alaska, apparently podiatrists have privileges to include hands there too. So we actually have a podiatrist who's within the Muslim Podiatry Network who practice in Alaska. And I wish she was here. She could have spoke on that a little bit, but it's just fun. So generally speaking, we can kind of break up our practice into these different categories here. Infection, trauma, musculoskeletal disease, biomechanics, neurovascular disease, dermatological disease, pediatrics, and then orthotics and shoe gear, if that is something that, and obviously not everyone's practice is going to have all of these components to it. Some of them, if you're more specialized, you do 1 or 2. Some people are more generalists and they do all of the above. So it kind of depends on where you're practicing, what your interests are, and all that. So let's see. So I'm just going to kind of go through a few conditions for each of these categories, basically, and then I'll pretty much be done. I'll take some questions, and then we'll let Dr. Akram go ahead. Okay. So for musculoskeletal disease, this could be. Sorry, I'm also admitting people while I'm doing this. Musculoskeletal disease, so osseous, so bone related. This could be structural, related to your arches. People have bone spurs, bunions. It could be arthritis related, so osteoarthritis, rheumatoid, psoriatic, gouty, and Charcot arthropathies. Cystic, things could be benign versus malignant, and then soft tissues, sprains, tears, ruptures, generalized inflammation, that sort of thing. And so I have a couple x-rays here, things that are related to musculoskeletal disease. And if anybody wants to shout out what they think this condition is, that would be welcome. Or if not, I'll just tell you. So I'll give you guys like 20 seconds here to decide if you want to try to guess what sort of condition this is based off the x-ray. And then I'll just move on if not. Okay, 20 seconds is actually a long time. So this is what's called a Martel sign. This is a classic sign for gout. Outside of a gout presents as outside of the joints, right? So the joint is over here. This is where the kind of gout or tophi would build up here on the outside of the joint. Anyways, so here's another x-ray of someone who likely had some arthritis in their joints. This is something that we would do, is basically fuse the joints that are demonstrating arthritis. People, generally speaking, don't use screws anymore for hammer toes or for arthritis like this in the toes, but this person did. Here's another picture of some arthritis here into the big toe joint, into the first MCPJ. This is obviously, depending on functionality, is either called hallux limitus or hallux rigidus. And this is something that you would do for that, or that we would do for that, is fuse that joint. Usually we use titanium hardware, so plates and screws that go across the joint, and we prepare the joint for fusion, and then the textbook says about 6 to 8 weeks is when that joint fully fuses together. Here's an example of someone who's likely has rheumatoid arthritis. You start to see the lateral drifting of the toes, and this is a procedure that we would, generally speaking, do for rheumatoid arthritis when someone has basically pain along all of their joints, is fuse the big toe joint and then resect the heads of the lesser metatarsals and kind of pin the toes to them. Here's an example of ankle arthritis with a angular deformity of the talus on the tibia. For ankle arthritis, generally speaking, there's various things that you can do. I like to approach this in a stepwise fashion. So firstly, I'd kind of talk to the patient about a steroid injection into the ankle joint, maybe adjusting what kind of shoes they wear, activity modifications, maybe use some sort of a brace. And then if that doesn't work, there's various things we can do. Ankle arthroscopy is one thing. So you kind of go in with a little camera and a little shaver, and you clean up any synovitis that may be in there. And of course, if you have an angular deformity like this, just an arthroscopy alone is not going to help. So there are various things that we can do for that too. So with someone with end-stage arthritis for the ankle joint, an ankle fusion is something that would be considered. Also nowadays, podiatrists are doing what's called ankle replacements. So that is basically removing all the non-viable cartilage from the talar surface as well as the tibial surface, and then you can basically put an implant in there. We talked about kind of the benign and malignant cystic conditions that also affect the foot and ankle here. Excuse I don't know if you guys can hear my daughter there. She's crying. But her mom's got her, don't worry. Here's an MRI of a peroneal tendon tear. Obviously, tendon tears and ruptures are something that we take care of. Usually, not something that will heal on their own. My kind of approach to this is, generally speaking, doing, conservative stuff, bracing, that sort of stuff too, maybe some physical therapy, depending on the extent of the tear on the tendons though. Really surgical management is usually indicated for these. For lateral ankle pathology, we do, well, you kind of assess the ligaments and the tendons there. So this is a procedure called a brostrum, which is basically reconstructing the anterior talofibular ligament and the calcaneofibular ligament when someone has significant ankle pathology. Basically, the way I describe it to patients is you're putting two bone or drywall anchors into the bone and then bringing the ligament up to that. And obviously, one of the tests that you would do to test for ankle instability is or ligament pathology is the anterior drawer sign, meaning pulling the ankle forward a little bit to kind of see, and comparing it to the contralateral side to determine if there's injury to the ATFL. I just put this in there. I know you all don't really care. So this is an example. Here's an MRI of somebody with an Achilles tendon rupture. You can kind of see the break in the Achilles tendon over here in the posterior aspect of the leg. And then this is an example of a repair of an Achilles tendon. So this is actually the muscle, the tendon over here. And then in this situation, we did a Krakow stitch on either side of the tendon and kind of anchored it down to the Achilles, to the calcaneus. This was a case I did in residency. There's a condition I'm sure you all are aware called, or there's a tendon, called the posterior tibial tendon. Sometimes you can get what's called an accessory navicular, accessory bone here at the level of the navicular. And so that can sometimes be symptomatic. So if you do what's called a Kidner procedure, where you remove the tendon, remove the bone, and then reattach the tendon. Obviously, plantar fasciitis, the plantar fascia is a huge reason why people come in to see foot doctors. I probably see about 3 or 4 every day. Someone's coming in with heel pain, and there's kind of a stepwise approach on how to treat that too. A lot of studies nowadays are showing that there's a significant really causation related to equinus and your Achilles tendon tightness or gastrocnemius tightness that actually cause the plantar fascia and plantar fasciitis. And so sometimes just addressing the equinus is enough to take care of the plantar fasciitis. And by that, usually, stretching, physical therapy, or even a gastrocnemius muscle release. Neurovascular disease. So, PAD, congestive heart failure, venous stasis, all these things can show up, can manifest in the feet and legs. This is just something I wanted to throw in there that I thought was interesting, that you all might find interesting. There are some podiatrists and foot and ankle specialists who are really kind of getting into the world of nerve surgery as well. And so here's an example. This is a paper kind of highlighting doing a peroneal nerve to deep peroneal nerve, superficial to deep peroneal nerve transfer using allografts and things like that. So it's pretty cool. Obviously, neuromas are a big thing too. Pediatrics, so clubfoot, AVNs, coalitions, and fractures, kind of the main sort of things that with to the foot doctor, but there's obviously more than that. This is just kind of a paper that I thought I got rid of here, but basically this is talking about how neuropathy and diabetes can affect surgery. This was a presentation I gave to some internal medicine doctors, and I wanted to include something that would be relevant for them to understand about diabetes control, but you all know that already. So shoe gear modifications and orthotics, this is something that we learned in school. We basically, this little wheel of materials here on the bottom right is, we had to memorize each material, the thickness of all the material, when to use it, when not to use it. And so there's, reasons to use each sort of material. Nowadays, I would say most people are not making orthotics in the United States in their practice. Most people are kind of sending it to like a third party or a lab where patients go get their foot molded, or nowadays I think they're just kind of taking pictures with an iPad and having them made. Sometimes they're being 3D printed. That's kind of the newest newest technology there. Dermatological disease. This is probably one of the biggest things that we as podiatrists in the US deal with. People with diabetes, nails, calluses, corns, warts, fungus, and then various types of skin lesions as well. And then infection. So infection, and I would love to hear more about your all's curriculum and what you all learn in school, or you're in school, or I guess what your scope is. But one of the biggest things that we deal with whenever we take like call at the hospital, we're seeing mostly infection cases. So usually that's people with neuropathy, right, who don't feel their feet, and so they develop wounds after pressure points, and people with infections, basically. So I would say that's, at least in my practice, when I get called into the hospital, it's because of a infection usually. Occasionally we'll do some trauma, some fractures and things like that, but usually it's an infection. Yeah, so I mean, it could be anything. A lot of times these patients are, they've had an infection for a while and then they decide to go to the emergency department. Sometimes, it's a new thing. Well, not new, but they've put it off for a long time, enough to where it's really unstable and they have actually become like septic. And so there's various things that we do to treat these wounds. Obviously, the biggest thing that you can do is prevent it, right? So we recommend that diabetic patients, depending on some variables, should be seen at least once a year. And then people who have had wounds or amputations in the past should be seen about every 3 months or so, just to kind of get their nails trimmed and get calluses, things like that taken care of, so that they can avoid any major infections and loss of limb. I thought this was fun. So basically, maybe this could be helpful for you all for your notes whenever you're documenting wounds. I like to use this acronym SLEEP Mode F, and basically, it's all written out there. So size, location, edema. Is there erythema? Does it? What's the wound base look like? And then does it probe to bone? What are the margins? Is there odor, drainage, edema, and fluctuance? The things that are ostracized there usually indicate an infection. Does anyone know what probing means, or what the significance of that is? If something was to probe to bone through a wound. Basically, the probe to bone test, there's a high specificity, or I guess, specificity for osteomyelitis. If you could take a probe or a cotton tip applicator through the wound and feel the bone, there's about an 87% chance that you have a bone infection there. And then drainage, obviously there's pus. That could be a sign of a pus forming bacteria. And then fluctuance is a sign of a really severe infection, indicative of like muscle necrosis, things like that. That's all I've got from my side here. Does anybody have any questions?
There's a question in the chat, Ellie, if you want to address it.
Let me see here. Sorry, I should have been looking at this too. Let's see. People are considered non-surgical method rather than surgical. Finance is a major issue of immune protective. That's tough. So let's see. Yeah. So to address Sarah's question here. Yeah, I mean, so I work at a university as well. We get people from what you would consider, the middle of nowhere, in the United States. So I said that, but yeah, I mean, sometimes you just have to seek treatment at a facility where they're not really worried about finance, or people are more just there to kind of get the job done, for non-surgical methods. Let's take like the ankle that I showed you, the ankle joint here. Let me pull that up again. So someone who has something like this, what do you do when they're in pain all the time and surgery is not an option? Well, I mean, really, they have to understand. I think it really comes down to patient expectations. They have to know that this is something that they're going to live with. If they can't, find relief with bracing or injections, or potentially some oral medication. Unfortunately, that's just kind of it's going to be part of their life going forward unless they can adjust their activities. I have a lot of people like that where they're like, or even if they're not like from an underserved or underprivileged area, sometimes it's a single mom who has 4 kids. She can't be off of her foot to have surgery. So it's just, you just have to kind of understand that, and they have to understand that it's going to be part of their life until they do decide to have that surgery, unfortunately. Yeah, exactly. Steroid shots, and then total contact casting. Exactly. Yeah. Let's see. What other questions do we have? What are your considerations for prolotherapy? Prolotherapy meaning like steroid shots, I guess. So generally speaking, they say that, and I have to find the papers on this, they say that the injections are not, it's not something that you should be getting regularly. I like the rule of thumb is kind of limited to about 3 times a year is kind of the rule of thumb that you'll hear at various practices here in the United States. I even would say less than that personally. I suggest that if you need, like, let's use that ankle again as an example. Like if this person comes in once a year and gets an injection, that's great. That's fine. If it's buying them some time, if it's buying them a year, I think that's great. I also tell patients once a year is fine. If you have a big trip to Disney World coming up, you need to kind of just make it through a week. That's a good time to get an injection. But again, just know that it's not the treatment. There's also evidence to suggest that it can thin out the skin, right? It can cause atrophy of the skin and various tissues as well. So in the long term, it can actually be a detriment, doing regular injections. So I always tell people, like, once, twice a year. If you need to do it more than that, then we should really be talking about the next step, which would be some sort of surgery. What other questions do you guys have?
I think Sarah has her hand raised.
Oh,
Sarah,
yeah.
go ahead.
And guys, feel free to, unmute yourself and ask a question if you'd like, or just go on to type in the thing, that's fine too.
So over here in Pakistan, we are doing a bachelor course in DPM, which is like a 5-year course. So obviously in America, as you have stated in the beginning of the session, it's quite extensive. So what are your opinions on that? Because I'm a second-year student and I barely knew some of these diseases that you spoke about.
Well, I think it just depends on, what is your goal with your career? Like, are you trying to, if you're hoping to stay, where you are, go back to your, wherever you grew up and practice there. I think it just kind of depends on what your career goals are. There's not necessarily a need to, I guess, to know more than you need to, in a sense, if that's within your scope. I guess perhaps more of the orthopedic type doctors are the ones who are kind of doing more of this stuff there. But if the scope within your area is, trimming nails, calluses, diabetic prevention, that sort of stuff, making shoes, bracing, that sort of thing. I mean, there's not, I don't see anything wrong with that. Does that make sense? Let's let Dr. Akram go ahead and do her presentation, and then we can come back and answer whatever questions y'all have.
Okay. Can you share my slides?
Yeah.
So my presentation is more interactive. I would need someone to kind of answer questions on each slide. Otherwise, it's not going to be fun. So are there any volunteers? And if you guys don't know the answer, it's totally fine. Don't worry about it.
Let's see.
Otherwise, I'm going to pick random people.
There you go. Is this working?
Yeah, I can see it. Thank you. We have a couple of Fatimas. Do any of them want to take the lead and start us? No? Okay, you guys are shy. All right, I'll just go ahead and run through the presentation then. If you guys have any questions, feel free to interrupt. So chief complaint, this is a patient that is a 58-year-old female. She's coming with left foot pain. Next slide. This is the HPR. This is generally what, whenever you write a note, this is going to be the top. It's going to have some of the pertinent things. So she tells you what's going on. There's pain to the medial arch or heel and then posterior malleolus. Pain is moderate, it's 5 out of 10, going for about 2 years, but it's worse over the last 6 weeks. She says there's some achings and it's slow and burning. It gets better when she rested, and then whenever she puts weight on it, it gets worse. Previously, she has tried orthotics and inserts, which helped a little bit. She has also had previous surgery, which was a synovectomy, and then she did debridement of the posterior tibial tendon in 2020. So once you have this, next slide, generally you want to know the physical exam. Or sorry, the basic stuff. So she doesn't have any allergies. She's on some lisinopril and metformin. Fairly healthy lady. Has surgical history, the one mentioned, family history, and then she doesn't smoke or use any drugs. Next slide. So for physical exam, the red is sort of more of the permanent stuff. The vascular, fairly benign, except that she does have some edema around the posterior tibial tendon. Her neurological exam is intact. These are like the big 4 categories that you do for pretty much every single patient that walks in your office. Derm, you look, there's no rashes or anything, but now the musculoskeletal is where you get a lot of information. So she has a pronated foot structure. She has pain along the medial arch. At the insertion of the PT tendon, the strength is a little bit decreased at 4 out of 5. You don't see any abduction at the Lisfranc or the Chopart joint. The mid-tarsal joint is unstable and there's some hypermobility there too. The ankle is in valgus and there's forefoot varus present. And then the big one is, of course, the gastroc equinus is present as well. Some of the other joints, the ankle, subtalar, the first MPJ are all within normal limits. Anytime you're thinking like musculoskeletal, doing a biomechanical or a gait exam is imperative as well. So for this person, when you watch them walk, you can see that their heel everts, and then at heel contact, and they have an early heel lift. They have an apropulsive toe off, and their medial talar bulges, and then the navicular drops. Next slide. We have some x-rays. This is where I would like someone to read them, but I don't think that's happening today. So you can kind of see the classic signs of what a flat foot would look like. You can see on the lateral, the AP, all the classic stuff that you learn in school. So next slide. Next slide, sorry. Classifications in diagnosis. So this is what you consider your classic flat foot deformity. We don't have any pictures of the feet, I'm sorry. We just have the x-rays. Yeah, PTTD, perfect. So in your diagnosis or in your classification is also called the progressive collapsing foot deformity, if you guys have heard of that, PCFD. It goes into more detail, but yes, PTTD or adult acquired flat foot deformity, all of those are perfectly accurate. And then also mention the forefoot varus and then the gastroc equinus. So all of those are going to be in your diagnosis. So next slide. So next question would be, so this patient has tried conservative care. She has failed it. She has had 1 surgery in the past. Based on that musculoskeletal exam findings, what kind of surgeries or procedures would you want to do to fix this fairly young middle-aged person's flat foot? If you guys want to type in the chat, that's perfectly fine. So triple is a consideration if flat foot is very severe. But for this patient, she had no pain at the subtalar joint or the other joints. So what are some joint sparing procedures you can think of? A tendon. So she already had some tendon work done. That's a good answer. But it failed. So she had that synovectomy and then PT debridement. So it wouldn't be too beneficial, unfortunately, at this point. She did have hypermobility at one of the joints, so fusing that would be a good idea. Do you guys remember what it's called if you have hypermobility at the metatarsal joint? What procedure would you do for that? So that is what the physical exam was. If you guys need more details, we can go back to it. If you want to just take a second to read over that. So the musculoskeletal exam kind of tells you that it is a pronated foot structure. Pain is around the PT tendon. So, you know, with the flat foot, the PT is sort of failing at this point. We don't have severe abduction at Lisfranc or Chopard, but the metatarsal is unstable. And then there's that forefoot varus deformity as well, along with that equinus present. So we don't have to address the ankle or the subtalar joint technically at this point. The TN is okay, the NC is okay as well. Any other ideas before I show you guys what we did for this patient? All right, we can go to the x-rays of what we did. So that's what we did for the patient. Can you guys tell what was done? I'll tell you, we did 3 surgeries or 3 procedures on this to correct the foot. The first one was that equinus deformity you want to address. What procedures can you do to address equinus? Calcanectomy. You could, I guess you could cut the calc and move it over. What would be an easier soft tissue procedure you could do? Yeah, Evans, perfect. That's what we did here. Evans sort of gives you like a triplane correction. So that is the plate and screws you guys see in the calcaneus. We did that. And then what's the other one that you guys see on there? So the other one is the lapidus, right? And it's sort of what we call like a lappy cotton procedure. So to address that forefoot varus, you can do a little bone wedge and bring that forefoot down to the ground, make it more perpendicular. And then the lapidus to address hypomobility. So you kind of do both of those at the same time. And then we do the gastrocnemius recession that Ali had mentioned earlier as well. So that's going to take care of the equinus. Anytime you have flat foot, gastroc is like a big driving force. And if you don't address that, you're going to get a lot of issues further down the line. So anytime you have equinus, there's a few procedures you can do. If it's severe, you can do like a tendon Achilles lengthening. Otherwise, you generally do gastroc recessions more commonly. So that was what we did for this patient. We can go to the next slide. So the goal here is to get that hind foot aligned and get the foot perpendicular to the ground. So we did all of those things. Any questions about this case before we do the next one? Okay. So the second case we have, this is a 75-year-old, so a bit older male. He comes to the clinic for left ankle pain. It's particularly with activity, and it's some dull, achy, and throbbing. There's no injury, and the patient says that there's not a lot of motion there. They have tried ankle foot orthotics, so they have tried bracing, but it rubs and it causes sore, so they're sort of done with that. Next slide. DPT 50, what is that? Oh, you do know what the DPT 50 is?
I don't know what that is actually. What is that? Sorry. Maybe we just keep going.
Yeah. Tell us, and then we can try to figure out why we didn't do that. So past medical history is unremarkable. They're just on Tylenol. So Pretty good, nothing crazy. They do live alone. That's probably the only important thing here. Next slide. Like I said, same physical exam on pretty much everyone. Neurologically, they're intact. Vascular is good as well. Oh, insoles. So they did, yeah. It said initially we tried insoles, but they failed. That it didn't get better. So we're doing surgery only if all conservative treatment fails. Surgery is never the first line. So generally, yes, you would absolutely do orthotics first. If it's like an acute inflammation to the PT tendon, you would put them in a brace, get things time to calm down. Modification with shoes and inserts and physical therapy. Those are all first line treatments. My presentation is sort of saying that all of those things failed, so we had to do surgery. So that's why these cases are more surgical. But in the future, if you guys want more conservative stuff, we can definitely talk more about that as well. But yeah, good question. So for this patient's physical exam, like I said, neuro is fairly intact. For vascular, they have some swelling at the ankle, but that's about it. Derm skin looks good. Again, the musculoskeletal is the most important, this as well. So they have palpation pretty much everywhere on the ankle joint, lateral, medial, anterior gutters of the ankle. Inferior to the malleoli, it hurts. Their ankle range of motion is decreased. It's painful, very tender. The sinus tarsi is also painful. And subtalar joint, we can't really move it, and it's very painful and arthritic as well. So we get some x-rays. Next, anyone wants to comment on these? Tell me which joints look really bad to you guys. Perfect. Subtalar joint and the ankle arthritis, exactly. So that's what we want to address. Next slide. So you always want to get, multiple views. You want to get weight-bearing views just to make sure you have a full picture. We want to see some calc axials, maybe Harrison beads, just to get that hindfoot stuff pictured. So just another extra for you guys. Next slide. Oh, sorry, go ahead, go back one more. Okay. So for conservative treatment, this patient, we did injections. It's very hard to get into that joint. You can see it's very arthritic. And then we tried bracing as well. And it said that patient kept getting sores on their ankle from that brace. And they're 75. They're active in the sense that they, live alone. They need to move around, do things for themselves, but they're not running or anything. And they're not actively working either. So they're retired. So based on that, what kind of treatment plan options are you thinking to address the ankle and the subtalar joint? Arthrodesis, exactly, yeah. And then we want to fuse the ankle and subtalar joint because those are both the bad joints here. And it wouldn't really help to do just one and leave the other one. There's a few ways you can do that. You can do like a plate. You can do a nail. And then if you look at our x-rays, we did a TTC. So we pretty much fused that with a nail, fusing the subtalar and the ankle joint. So the way you do that, I can kind of go a little bit on how you do this, but not super detailed. So you basically make an incision on the lateral aspect. You want to expose the subtalar and the ankle joint. And then you really want to prep those joints, so get all of that bad cartilage out. Use whatever you need to do. You want to drill it to kind of get all the good juices flowing in there. And then main thing is going to be get your alignment right. So you never want to put them in varus. You want to make sure the hindfoot is aligned and everything looks great. And you put your temporary fixation in there. Let's see what the question is. No, so we do this with them laying flat, not lateral, because you do. So lateral positioning would be good if you're addressing like just lateral ankle pathology, like peroneal tendons. But for this one, you really need to look them at all like straight as well. So just having them lay supine is beneficial for them. because that nail, you actually drill from the heel up into the tibia. So you're drilling where their foot is like slightly hanging off the edge of the bed, and then you're drilling from the bottom into the tibia. And then you also have to throw in some screws from P to A, like in the calcaneus, just to kind of hold everything in place really good. You can get like bone graft. You can get that from different places. You can even get like synthetic bone graft, and you fill that with any defects. And that's pretty much it. We also have to do what's called like a takedown of that, the lateral aspect. Some people you take it down, you put it back up, or you can just kind of leave it out. It doesn't matter, just because everything is fused. So that's why you don't see the lateral malleolus in there. I'm not sure if you guys see too much of this, so I thought it would be something cool just to kind of see like the scope of podiatry and how much you can do with it with a case like this. So next slide. So post-op, if you do something this big, is you need to really keep them non-weight bearing. So initially you can put them in a splint, then you can put them in a cast, and then you can have them start putting some weight in a cam walker. And then after about at week 13, they can be weight bearing as they can tolerate it and do bracing as needed. This patient does live alone, so that would be something you want to look at if they're not really going to be able to take care of themselves. So a long-term rehab facility or something is necessary as well. That's all I had. Do you guys have any questions on that case? All right. Any questions in general, guys? Yeah, post-op pain is super important. So generally for any of these bigger cases, you ask the anesthesiologist to do a block. So they would do like an adductor block just to get you some pain relief for the next few hours. And then typically hydrocodone, that's my choice, like 10 milligrams for the immediate 5 days. You can do tramadol if that works beneficial for you. They're not walking, so you want to consider DVT prophylaxis as well. So I generally just do aspirin, like a full aspirin twice a day. That works okay. Or do you do anything different?
So for my bigger cases like this, honestly, just where I am in my practice right now, anyone getting a TTC or, sometimes bigger flat foot recons involving fusions, things like that, I'll actually admit them overnight. That a lot of my patients, like I said, kind of come from the middle of nowhere. So especially if they have like a more than 2-3 hour commute to get to the hospital, a lot of times I'll keep them overnight, mostly for pain control, also to be seen by physical therapy and occupational therapy the next day. A lot of times people say, oh yeah, I can stay off of it, but then they go home and then they start putting weight on it and whatnot. So I find that it's helpful to keep them overnight. In addition to the anesthetic block, I typically do, for most surgeries in general, I'll alternate extra strength Tylenol and ibuprofen that they take every 4 hours. At night, they'll take an oxycodone, stronger pain medication. And then I'll also sometimes have, like if they're admitted in the hospital, they can have Dilaudid kind of on as needed for breakthrough pain. And then for larger cases too, especially involving hindfoot fusions, I'll keep like a Flexeril, a muscle relaxant available as well.
The other question was the post-op protocol. That was on one of the last slides. So with something this big, you're going to keep them not weight bearing for almost 3 months. You can do that by putting them in a cast or usually a cam walker, and then slowly start having them put weight on the heel. Physical therapy is going to be important too, just to make sure that they're not losing a lot of that strength. And then this is, one of those things you're not going to do the surgery if they don't have any support system, or if they're not able to be in a care facility afterwards. So those are also important factors before you ever do surgery on someone is, are they able to take care of this afterwards?
Dr. Junaid Khan has a question for the students, and this would be kind of helpful to hear in general about what is your, and I kind of was asking this earlier, what does your all's curriculum look like? What are kind of the typical jobs, like the scope of practice for people in Pakistan? And your all school is in Karachi, right? So are most people from Karachi, or do people travel there? Or I'd just love to hear a little bit about that.
So, hey, Dr. Masood and Dr. Arwa. I'm Shazadri. So, I've talked to Dr. Junaid regarding this. And so, firstly, our medical school is preparing some non-operative uh, post-graduation in Pakistan as well. But one way or the other, in order to perform surgeries, we have to move to England. I don't know about that, but our faculty is doing work on that. Uh, they are doing some really hard work regarding getting a podiatric in a regular field as a regular field, but they are preparing for a non-operative career in Pakistan. But for surgeries, I might think that it is not possible for years, a couple of years, but then they can in Pakistan they can do some things, so some changes in the curriculum so that we can perform operations or do operative things in Pakistan as well. But for now, for surgery, to perform surgery, we have to move to UK in order to get the graduation degree. So that's
And then
so-
do people, is everybody from Karachi, or do people travel from different
no.
cities?
Mostly people are from Karachi, but they live in Karachi in order to carry on their studies. So that's it.
Okay. And then
So you were
is the, go ahead, sorry.
So you were asking the questions in the first at the first, but I could not answer you. But so the Doctor of Podiatric Medicine is under the Allied Health Science. As it in Pakistan, it is as in it is going on as an Allied Health Science degree, but it is not under the Pakistan Medical and Dental College. So right now it is under Allied Health Science Council. So as you know that we cannot perform surgeries under the Allied Health Council, so we can do most non-operative things in Pakistan. And talking about that, this is the only university in Pakistan that is offering podiatry is Ziauddin University, and it is located in Karachi. That's it. And we have almost 6 batches, or almost more than 200 students that are doing this degree in Karachi right now. And just one batch has been passed out from and they are going to get their degrees in March or so. But it is really early for us to say anything. But our faculty and all the members are doing their job, and inshallah they will do good in this. As you know, it is in the early stages. And one more thing, that diabetes is the most concerning diseases in Pakistan. So for that, it is still growing. Podiatry is in this initial stage, but it will grow inshallah, and they will do some good thing for us. And it was really nice, good to connect with you. I was talking to Dr. Junaid regarding you guys, and I would highly appreciate if Dr. Junaid might have said some word regarding the Muslim Podiatry Network, because it is good to connect with people that are in your field and they are doing good jobs in your field. So, but he told me that he is going to listen to you guys today, and I would really thank you guys, you, Dr. Masood and Dr. Arwa, and I highly appreciate your time that you give us, and we look forward to see you again, inshallah.
Of course, inshallah. Yeah, Junaid, he may be able to get on and answer some questions or speak, or maybe not.
Yeah, hey guys, assalamu alaikum. Hey, this is Junaid Khan. Thanks, Dr. Ali and Dr. Arwa, for the presentation. I'm watching my kids today. When they're babies, they're a little bit easier, because they're in one spot. But once they're 2.5 and running around and they have to be entertained, it's a little bit more complicated. So I really appreciate the information. You guys are asking good questions. About the Muslim Podiatry Network, I mean, as Dr. Ali said, a lot of kind of what we do is based in the US. Obviously, the challenges of being a Muslim American podiatrist is very different than being in a Muslim country, obviously, right? I mean, here you have people that will ask Muslim brothers to shave their beard to get a residency, or for women, unfortunately, to, take off their hijab, things like that. Or certain geopolitical things happening in the Middle East, right? So, and these things can dictate sometimes your career or your training sometimes. So not a lot, not a lot, but a few incidents here and there. So that's kind of how Muslim Podiatry Network kind of came together, because as you know, many Muslims, they are not united. They don't work together. They don't collaborate, right? So this is just an initial step that we took, and they turned into something, you know, greater than that. We're doing educational things, mentorship. We're doing advocacy in terms of how we can benefit you guys and you guys can benefit us. I mean, if you guys have any research projects or anything that you want to run by us, we'd be happy to, you know, see how we can help. If you feel like your curriculum is lacking in any way, if you feel like, you know, Dr. Ali and Dr. Arwa were going through x-rays, and even if you're a fifth year about to graduate and you have no idea how to read an x-ray, that's a problem, right? Especially if you want to pursue surgery, that's a problem. If there's something that, you know, in the future where you have to take an equivalency exam in the UK in order to get a residency to do surgery, but you can't answer that this is gout on an x-ray, that's a problem, right? So if this is a new thing, I advise you guys to, if you're a fourth year or fifth year about to graduate and you struggle to go through this presentation and you were lost, then maybe collectively come together and talk to your the leadership there and say, hey, you know, if we are going to have a pathway to surgery at some point, you know, we want to make sure that we're comfortable reading an x-rays, we're comfortable naming procedures, right? If you look at an x-ray and there's end-stage arthritis in the big toe joint, right? I'd say the majority of students probably in the Madrid school, the UK school, the US schools, they'll be able to tell you what procedure that they need to do. So if you're looking for equivalency internationally, right, you have to make sure that you can follow some of these presentations. And if you can, that's okay, but take notes, not just for these talks, for any talk that we do. We're going to do case reports. And, you know, I mean, there are plenty of Muslim podiatrists, some of whom even speak Urdu, that maybe, you know, if you guys want to offer them to do talks for your school or whatever, you know, that option's there as well. So I think that's one way that we can probably help each other. And yeah, interested to see how things grow for podiatry in Pakistan. It's very exciting.
We have a couple more questions here. Sarah Fatima had asked what guidelines we were using. Could you explain your question, Sarah? I'm not sure what you're referring to.
Yeah, she was asking in regards of the pain management, that what guidelines do you?
So pain management is a really big thing. I'm not sure how it is in Pakistan. Here, there's a big push towards avoiding pain medication if possible. So there's a lot of research out there that has been targeting, you know, what are different things that we can do other than just giving people a really strong narcotic medication, because the chance of addiction is quite high, especially in certain areas in the United States. So there are studies out there that talk about, you know, alternating the ibuprofen and Tylenol, also, you know, avoiding the narcotic if possible, using more like muscle relaxants, more nerve type medication like gabapentin or Lyrica as well for after orthopedic surgeries. So they call it a multimodal pain control approach. That's kind of the buzzword. If you look that up, I'm sure you would, you come across a ton of articles. But you know, kind of the old practice was basically just give everybody what's called an oxycodone or Percocet or some sort of pain medication. But nowadays we're starting to move away from that and go into more of that multimodal approach. Sarah Salman asks, why only podiatry? I'm assuming you mean why did we choose podiatry? Dr. Akram, do you want to answer that?
Sure, yeah. I think from this presentation, you kind of get an idea of what the scope of podiatry is currently in the United States. It has been present for a while, and it is fairly well established. And within podiatry, you can kind of take the lead on how you want to practice once you graduate. So most everyone in their school, and then to some extent in their residency, are getting a similar level of training. But after that, if some people want to be just non-operative, they can do that. If they want to go into like a heavy surgical route, get more training, they can do that as well. So it kind of
I
helps
was
you.
asking,
Yeah, go ahead, Sarah.
basically, I was asking that you guys are talking about the Muslim Podiatry Network, right? So you're saying that you have to go through some kind of not so good things. So why only podiatry? Do other fields not have to face something like that?
So being a Muslim in America, it's tough regardless. So every field at every level has some sort of, prejudices that you have to face up to. I think every field needs a cohesive group that can help them with that. There wasn't anything for podiatry until Janae, then Ali kind of took the lead on this and started the Muslim Podiatry Network. So that's why.
There are Muslim organizations in other fields as well, like there's a what is it called, American Physicians of North America. APNA is a big one. So American Muslim, I don't know exactly, but there's basically there's Muslim organizations for most fields, and podiatry didn't have one, and so that's why we kind of started it. Okay. Well, if there's no other questions here, we'd love to connect with anyone who has questions or anyone who just wants to follow along with what we do.
And yet, I do have another question, if that's okay.
Sure.
So as far as prescription is concerned, can you guys just basically prescribe anything? Because as far as we're concerned, in the UK, they can apply and supply, but not really prescribe. We don't know what we're going to be able to do yet, because like someone said that it's still an emerging field. So what's that like in US?
You want to?
Sure, yeah. So generally you are managing only if they come into you for foot pain, that's what you're going to be addressing. You're not going to prescribe them their like high blood pressure medications or even diabetes. You're not managing their diabetes, but if they have any issues related to that, you can prescribe medications. So mostly it would be managing their pain. Even when it comes to like neuropathy, like with diabetes, that's going to be like a specialist who is going to be managing that most likely. At least in my practice, I don't think most podiatrists are managing any long-term health like issues with medications.
Assalamu alaikum. I have one question. Can I ask it? Hello?
Yes. What was that?
Yeah, it's Muhammad. So, Maksud, I have a quick question about it. I was asking about the guideline. So basically, in guideline, I know that for the high risk patient, we use the UT classification, and I don't know about what you use in the States. Basically, I know you're going to use this UT classification, but along with it, do you guys use the Wi-Fi and the SINBAD as well for the high risk, or just the UT?
So you're talking about for diabetic foot
Yeah,
injections?
that's like it. The UTSA and the Wi-Fi.
Yeah, I would say the most. So I think it depends on your practice. I think if you're managing consistently diabetic feet, you're probably within like some sort of a health system. I would say the most commonly recognized across specialties. So I'm talking about general surgery, internal medicine, emergency medicine is probably the IDSA guidelines. I think that
the last 23 1 year.
Say that one more time. I'm sorry.
The one which is given by the IWGDF 23.
I guess that would be.
Yeah, I think it's that one.
That's the recent one. Yeah.
IDSA is the Infectious Disease Society of America. That's the one that I have found that most specialties are using. As far as staging, like diabetic foot ulcerations, the Wagner classification is the one that's most widely used as well. That's the one that if you go to the emergency department, you'll see a poster of that hanging on the wall somewhere. So the more advanced ones like the UT or the Wi-Fi, I wouldn't say that I've seen that Wi-Fi has caught on to other specialties yet. That's something that as part of my training, I try to help educate other people as well. But it's definitely the most comprehensive, I would say, and we should be using more of it. But that's something I don't think it's caught on yet.
Thank you. And how about the MSK one? Because earlier there was a case which was showing by the Dr. Arwa, and she was mentioning about the guideline. And sorry, I didn't get that one. But what was that guideline? And a part of it, what guideline do you guys use for the MSK?
So I think that was referring to the flat foot. So
Yeah.
every pathology has its own, classification system, and that's based on different papers that are out there. That one would be the AAFD or like PTTD, or like the newer one is the PCFD. So sorry, there are a bunch of acronyms. All of those
CTD.
can be used. Yeah, PTD is probably the one that I think most people
Yeah.
are they know about. Yeah.
Thank you so much.
Yeah, you're welcome.
Danish, did you have a question?
Yeah, I have a question. My question is that means you are talking about the Muslims that they can face a difficulty in United States or England or USA. So I have a question is that my question is that if a non-Muslim is living or going to the USA or UK, so he or she can face same difficulties.
I think so. Anyone can face discrimination based off of anything that's going on with them, right? So a lot, for example, like sometimes you'll have non-Muslims who are African American or they're black, and sometimes they get treated differently. Oftentimes, women in medicine get treated differently than men would, right? And then so similarly, Muslims, maybe I guess not similarly, but Muslims can also face certain discrimination, right? Like Muslim women can be asked sometimes, and Dr. Akram, if you want to speak about this, you could. If not, it's okay. Sometimes Muslim women are asked to remove their hijab, for example. We've had Muslim men, like Dr. Junaid said, being asked to shave their beard because it just doesn't fit in their standard, I guess, understanding of what a physician is, So Muslims definitely face certain things here. And like you said, it's not very, very common, but it does happen, unfortunately. And so that's part of what we're trying to do is give people resources to report these things when they do happen.
So by your conversation means what you said told us. So non-Muslim don't face any kind of these difficulties. Am I right?
I mean, they wouldn't. Oh, I see what you're saying. Like, has a non-Muslim been asked to shave their beard, for example? Is that your question? Yeah, they could be. Yeah.
So it would also be someone like anyone that doesn't meet like the norm of what, an American person would think they can potentially face discrimination. So if you have like, let's say a Jewish person with like, a beard, or if they wear like the little, I'm forgetting what the name is, but their little hat. Yeah. So anything that's, not typical, anyone can face discrimination, right, in the United States. So it's not just Muslims, but Muslims do face it quite often.
Thank you so much, guys.
Yeah, of course.
Of course. All right. Well, we should wrap up. Again, it was awesome talking to you all. Thank you for having us. And Shahzad, I don't know, are you in some sort of leadership position at your school that you reached out, or are you just decided to reach out?
I just know I just contacted Dr. Junaid regarding this, and I like this idea regarding the Muslim Podiatry Network, that how we help the Muslims all around the world as in the field of podiatry get connected to each other. So it is a good idea, and we as an emerging career in Pakistan podiatry, we need some guidance other than our faculty and our colleagues. So that is why I connected to Dr. Junaid, and I talked to him regarding it, and he said, "You are most welcome. We can do that for you guys." So that's why I'm not in a leadership position in anything like that in our university. I'm just in a third year student.
Okay,
But
great.
mhm.
Thanks for having us. I posted our Instagram and email there. Feel free to contact us with anything. And
Sure. I think they had already connected to you guys via Instagram and YouTube as well. But
good.
they will.
All right. Anything else, Dr. Akram?
No, that's it. Just, really, we'll figure out how we can help you guys the best. And if you guys have anything in particular you're interested in or learning about, feel free to reach out and we can figure something out, inshallah.
Sure. Thank you so much for you guys.